Greetings, everyone. Sorry to interrupt your dinner tonight. I'm Dan Bockmann. I'm a chiropractor. And I know we have had, I don't think anyone from this room has shadowed in our clinic yet, but we have had a fair number of previous generations of y'all come in and shadow with us. But a little about me. I have a sports med and rehab clinic where we do pre and post-surgical rehab for spine and extremities. So not just backs or spines. So, we do post-op rehab, so could be ACL reconstruction, post-op rehab, or labral tear repair. Basically any moving parts, bunionectomy, rehab afterwards. Essentially I do kind of high-end PT. So, and we have about half athletes and half normal people, I call them. So, and it could be soccer moms or executives or business people, and it could be, I mean, I've worked on Olympic gold medalists and rock bands on set at a concert. So, I mean, it's kind of a wide variety of cool things that we get to do. But someone was mentioning earlier, said I should tell my story, how I ended up in this place. So, it's kind of interesting. So, when I was in high school, I was a senior, and they gave us an aptitude test and a skills test, just to kind of see what direction might seem interesting. And both of mine said I should become a chiropractor. And I asked my counselor, I said, what does a chiropractor do? And she said, I think it's a bone doctor of some kind. I was like, oh, well, that sounds cool. So I went pre-med, and then I kind of got distracted with college life. For honestly about a decade, and I attended bar and partied a lot and tried a lot of new things and took some classes here and there. And then I got married and I decided, hey, I don't want to do this for the rest of my life. And so my wife said, well, why don't you look back at chiropractic? So I looked back at it again and still didn't really know what it was. And so I figured I would just call up a bunch of docs and ask them what they do. So I called 10 different docs. And I was amazed. All of them said yes. And so I showed up and just kind of spent some time, grilling them. And I had a list of questions. And I said, so what's the best thing about your job? And what's the worst thing? And what would you change now, knowing, or in the past, knowing what you know now? And what kind of income can you make? And where do you see the profession heading? All the things you might care about. What's an average day like? And I got wildly different answers kind of from all of them. So I saw everything from just kind of small, sad offices to like thriving, vibrant, happy, fully staffed professional offices. And from a couple of those, kind of the better ones, it looked like something I could enjoy doing. And in fact, one of the docs I called happened to be the chairman of the Board of Regents at one of the schools I was considering. So he told me, this was in 1996, he said, he called up the president of the school and he said, I'm sending this guy to you, take care of him. I was like, wow. So we ended up going, and the president and his wife ended up giving us a tour of the campus. We had dessert at their house. I mean, it was kind of amazing. But the same doc who sent me to the president said, he said, when you get out of school, look me up. And he said, I'll give you a job. So let's see, 96 to 2001. So 5 years later, I called him and he gave me a job. So that's another cool benefit of just kind of like calling people at random or going through these shadowing programs. Plus it gives you kind of a peek into what the thing is that you're considering, what it's actually like. Because I mean, y'all are making a huge time, a huge energy investment, huge money investment, and you get out the other side and you're like, I hope this is something I like, right? But if you, all the opportunities you get to talk to someone who's in the field, get a bunch of different opinions, it'll help you shape up an opinion that can guide you toward a direction of something that you truly love. And I truly love my work, I will say that. I feel so fortunate to have kind of happenstance fell into this thing that I just really enjoy. And by the way, if anyone has questions along the way, just raise your hand. We'll do some more at the end, but if anyone wants to, wants some clarification on something, let me know. But just for an example, this morning I had a frozen shoulder patient. So it was a lady who'd had frozen shoulder. It's called adhesive capsulitis. It's one of the least understood musculoskeletal problems that exist. It's one of the most frustrating ones because it can happen as a result of an injury. Basically, the shoulder just kind of glues itself together. And there are kind of phases it tends to go through. There's the freezing stage where it just gets stiffer and stiffer, and they'll just find, I just can't raise my arm, or I can't fasten my bra strap or wash my hair. And then there's a painful stage. Again, these are common patterns, but they don't all follow this same path. And then it often, or sometimes it just spontaneously resolves, sometimes over a year. In fact, the lady who came to see me had already been to an orthopedist, and he had told her, oh, there's not really much you can do. It'll just be about a year, and it'll just kind of slowly come back. So I do rehab these patients, and we do get much faster results than a year. It's usually 2 or 3 months that we get significant improvement in range of motion. Range of motion is the big thing in any joint, but especially shoulders. But it's the key for this particular condition that I've found is really aggressive stretching often. Basically trying to force the shoulder to move in all the directions it does not want to go. So the big ones that are usually limited in this condition are external rotation of the shoulder and like adduction of the shoulder, which is kind of reaching if you were trying to shoulder your fingertips on the other side. Those two movements, and then of course raising up an arm overhead. Those are kind of the top 3 that are the most reduced. And of course all movements painful. But this, again, this particular condition, it can happen after an injury. So if you fell and caught yourself, which she did, and she didn't feel like a lot of pain, but she just kind of babied her shoulder for a couple of weeks. A lot of times that's all it takes for the shoulder, the tissue to just kind of stiffen up. But other times it's just spontaneous. It's out of the blue. There's no clear cause for it. Now there's some risk factors. Women get it more than men. Commonly diabetic, commonly thyroid issues. So both of those things are kind of immune system, metabolism things, and so if you have thyroid and or diabetes, it just complicates any condition, which y'all will learn quickly, no matter what specialty you go into. Diabetes and thyroid issues tend to just make everything take longer, whatever the problem is. And then I had also today had a pro bass fisherman with severe low back pain, and he came in with his wife, and he has a big tournament. He has a major tournament this weekend, so he was like, I need to be on the boat because this is how I make my living. And he couldn't bend over, couldn't put on. His wife had to dress him that morning, so we got him walking out of there like probably 50% pain free, just from one session. So that's the kind of stuff that's super gratifying to me. It's being the diagnostic detective. So that's how I see the job of any doctor. I mean, that's how I like to approach it, because first of all, it's a mystery, right? So the crime is the pain, the victim is the patient, and the patient is the only eyewitness to the crime. So it's your job talking to them to get all the relevant details from them. They don't know which things are important. So you have to kind of parse those out and assemble a suspect, which is the diagnosis, and then prosecute it with treatment, and then solve the case by restoring full function. And that's really kind of how it is. And it's never, well, I won't say it's never the same method or the same pathway to fixing a problem for every patient. There are the huge bulk of patients you'll find with a particular condition. They'll all kind of follow, they have a lot of similarities to them, and they'll respond in a way you expect, maybe 80% of them. But then there's that 15 to 20% on the outside that have some mystery responses, or they don't respond the way you should, or you do this thing you were expecting to work and it didn't, so you have to change course and kind of figure out what their specific path is. So solving that mystery is super fun. And then, especially if I have patients who've told me, yeah, I haven't been able to run for 10 years. I blew my knee out or something like that, or my feet won't let me run, some limiting factor. So I always like to find on day one during the consult, I ask them, what are the activities you're most limited from that you would like to be able to resume doing pain-free? And they'll know what those things are. So whether you're going, into internal medicine or surgery or whatever, every patient has their goals. They have the things that their dreams, and sometimes they'll say, well, I'd like to be able to run, but I know I can't run. I'll say, hold up now. we don't know that yet. You think you can't run, but would you like to be able to run? And they're like, well, yeah. I said, well, that's going on the list. So then those are my targets that I try to work them up toward. And most of the time we reach those targets, but even if we get 80% to them, they still have a much fuller, richer life. They can pick up their kids again. They can walk up and down stairs. They can, go camping or play kickball, whatever they want to do. And that's just seeing the happiness that comes from that is hugely rewarding for me. And pain in general of any kind, again, I'm working mostly with pain, disability, weakness, and it's mostly pain that limits people from things. If it goes on very long, it's depressing. There's a very strong psychological effect to all injury, especially the longer it goes on, especially the more people they've seen, more docs they've seen, more therapy they've had, didn't work. They start to despair. They start to, well, maybe this is just the way my life's going to go. Maybe I'm just going to be that person who has to sit while everyone else is standing at the football game, because I can't stand very long because of whatever thing hurting. But of course, if they came to see me, they haven't given up yet, right? Because if they'd given up, they wouldn't be there to see me. So there's some hope left. So I like to stoke that little fire and grow it. And let's see, my background, I started practicing in Houston in a group practice, which in my profession, we don't have as many options coming straight out of school as you guys may have. You guys have hospitals and groups and private practice and government programs and stuff. And we have some of those things as chiropractors. We don't have the full list. I did start in a group practice and discovered really quickly that this was not the kind of practice I wanted to run. So it was long hours. We worked 11, 12-hour days. But it was super fun because we get a chance to get hands-on patients and talking to patients and interacting with them and figuring out how flow works and figuring out what being a doctor really is about. So it was hugely valuable. I did that for a year or two. Then I moved here to Austin and worked in another group practice as an exam doc. And this particular doc, who was the one who sent me to the president of the school I ended up going to, he would pay me, he had me on salary to treat his patients, but then during off hours when he was not practicing, he said, you can grow your own practice during that time. So I had a fully outfitted clinic and staff, and it was a wonderful, wonderful opportunity. And then I would just pay him 40% of whatever I collected, which may sound like a lot, but if you open your own practice, your overhead starts off being 100% of what you collect. So, but it gave me a chance to grow my practice, and then I outgrew his space and then opened my own place, and I now have an MD. I practice with an MD and a PT, so we all share space, separate practices. She is a physiatrist. Does anyone know what a physiatrist is? It is, I call it the medical specialty no one's ever heard of. They also call it PM&R, physical medicine and rehabilitation, which sounds like what I do, but in fact she does, her day is much different than mine. So she ends up doing a lot of case management. She does diagnostic ultrasound for a lot of joints. She has a lot of patients who come in with wheelchairs and motorized chairs, and she's doing disability evaluations. So her patient population far different than mine. Mine are generally more active. But it's nice to be able to kind of bounce ideas off each other. You'll find that pretty quickly, especially as young docs coming out of school. It's nice to have someone else, even if it's just another fresh grad, but especially if it's a doc who's been in practice for a while, and they can say, and you're just trying to figure out what's the best course here, and they go, oh, just try this. I learned this after 5 years in practice, and you go, oh, thank you. So those little tips and tricks, pick them up any chance you get. And I have a PT/LMT, which is licensed massage therapist, who rents room from me. It's a great, happy, bright, open, fun environment. We have a great time. We joke and laugh, but we make sure it's all very fast paced. By the way, I'll just give y'all a personal invitation if y'all haven't been offered it yet. Anyone who wants to come shadow with us, you may have to go through your channels or whatever, but we welcome you. So we have AED, another medical pre-med honor society. we've probably had 40 or 50 of them come through over the last 3-4 years. We limit it to 4 at a time, just because the rooms get crowded. But if you just call our office, and I'll give you all my contact info. I'm sure your leaders have that, but just call our office, and Sandra, my assistant, can help you all decide, okay, we don't have too many on this day. And y'all can take notes, and you can chart. You walk through the whole thing. You get to see consult, exam, history. You get to see subsequent visits. You get to see release from care, return to play. These are all just the kind of stages of treatment and release of a patient. Let's see, what else? What else could I tell you? So the band, 30 Seconds to Mars. So it's been a year or so. They called me and said, hey, our band's doing a concert and some of them need some care. Would you be willing to do it? And I was like, yeah. So they had me come out to the 360 amphitheater out at the Circuit of the Americas. And I went into he had brought me into his trailer, and he had a rotator cuff issue. So I did some work on him there. And when we were done, and he was just the nicest guy. He was the drummer. And we're done, he said, hey, would you mind watching me while I play and just see if you have any advice for me? Like anything I might need to do? And I was like, sure. He said, come on out here. Walked out. I didn't realize he was bringing me out with the band, packed house, crowd jumps up, and then he says, here, stand right here. And his drum kit's right here. He's sitting right here, and he just said, stand right here. And I was like, okay. So I just kind of hung out for the entire concert right next to Jared Leto and his brother. And that was something I didn't ask. I didn't try to get that gig. The reason they found me is through reputation. So reputation is how pretty much everyone finds me. I'm the top-rated doc that does what I do in Austin. And so we have tons of great reviews online. We're fortunate to have lots of happy patients. And I attribute that fact to the fact that all I care about are results. So getting patients well quick. It's not just getting me out of the pain now. The even bigger win is keeping the pain from coming back. So once I've done a consult and exam with a new patient, for example, my report of findings, which is my explanation of what I found, what I think it'll take to fix them, their prognosis, how I think they'll do after. That's the report of findings. It's kind of a summary. My report of findings sounds pretty much like this, word for word. I don't see anything scary. I think you're going to be super easy to fix. I do see 2 kinds of problems that are both very fixable, and they are tight things and weak things. Tight things meaning muscles that are shorter ropes than they should be, and tight muscles matter because they limit how far you can move, and that means you're being forced to move abnormally, which can cause pain. Weak things meaning I suspect some of the muscles whose job it is to protect you can't. That can allow pain to happen too. So the solution, loosen tight things, strengthen weak things. So I use 0 medical jargon so far, right? And patients get it. It makes sense, right? And I say, then I'll say, I bet we can get you at least 80% better in 3 sessions. You'll be equipped to get the remaining progress on your own. And most importantly, you'll be equipped to not need me again for this thing. No offense, I want to see less of you. They like that. And I say, I will further predict that you have significant improvement in 2 sessions or less. And that means significant to you. So if you and I see each other twice and you tell me, hey doc, I'm definitely starting to feel better, great, we'll do a 3rd session. If that did not happen, we'll change course until we do get you on the right path, which could mean imaging, it could mean a referral to a neurologist or an ortho, whatever is appropriate, that's what would happen at visit 2. But I end up usually saying, but I don't think we're going to need to change course because I think you're going to do great, and I am usually right. And the reason I can be that confident is because it just happens over and over and over. So, and I attribute that to, I've developed my own rehab protocols. So they're a super simplified version of all the many, many physical therapy and musculoskeletal treatment programs out there. I just distilled them down into their essence, and it really comes down to, when it comes to moving parts head to toe, you can really only have two kinds of problems. You can have mobility problems and stability. Mobility meaning I should be able to move this far and I could only move this far, or that's too little, or it could be too much mobility. So if I tear my ACL, my knee is now sloppy, right? That's too much mobility. Or if I break a bone, too much mobility, right? And stability, the muscles whose job it is to protect you, can't. So if I was to stand on this chair and step off and went limp in midair, I'm going to get hurt. Even though I can do it safely right now, but my muscles absorb the impact, my muscles protected me. And that's the same thing that happens for all joints. If your muscles are able to protect you, you don't get hurt. And if your joints are able to move in a safe way, they don't get hurt. So all we do is look for those two deficits. Now there are some other things too. So for example, we've mentioned diabetes and thyroid, right? These are kind of layers of extra contribution. So if a patient has diabetes, it's going to slow healing in general. If they have thyroid issues, it slows metabolism, and part of metabolism is healing. If they're anemic, if they're dehydrated, what if they're only getting 3 hours of sleep a night? So all these things have an effect. They just have varying degrees of effect on the overall problem. And even y'all, if y'all are internists or orthopedic, whatever specialty you're in, there are always multiple contributors to all issues. There's never just one. If someone's malnourished, they could have an absorption problem in their gut. You know, they have Crohn's or IBS, or their diet could be bad. Maybe they're just not getting the nutrients in them, and their body could absorb them, but they're not getting them. Or maybe they have an eating disorder. Or maybe, I mean, there's a million, maybe they're high stress, and so their peristalsis is sped up, and so they don't have time to absorb. So stress could be a contributor. All these things. See how there's a kind of a pile of different things, but that contribute at different amounts. So my goal is always to find the biggest contributors to the problem, identify them first, so that when we fix those couple of big gnarly things, that we see some big reduction in symptoms. Then we can kind of start picking off all the other things. Sometimes I'll have a patient come in and I'll identify lots of moving mechanical problems, but they haven't been sleeping more than a couple hours a night for a couple weeks, and I'll say, no matter what we do to the rest of you therapy-wise, if you're not getting sleep, it's going to bounce off you. It's not going to make a difference because you have such a huge sleep deficit. So I'll say, figure out, you know, if you've used some sleep aids, or if you have some meditation or anything that you can find to get some sleep for 2 or 3 nights, kind of catch up a bit on your recovery. Then we'll start on this other stuff and it will take hold. But otherwise, there are some contributors to injury and pain that no therapy will fix unless you address the underlying problem. So, any questions from anyone so far? Yes?
So you said that your patient population is really different from your MD person. Do you and the physical therapist work a little bit more closely together than some patients?
Strangely, no. We're all separate. We share space.
Okay.
Now, we do occasionally refer, in Texas, PTs need a referral from a doctor. And so I'm happy to do a little quick eval and then she has a patient already, but she needs a referral, so I'll do an exam and send the patient over to her. We don't collaborate a lot. I do all my rehab hands-on myself.
Okay.
So it's one-on-one. So if you're a patient of mine, we are going through it all together. Now I've definitely consulted with Lori Wasserberger, MD, who's the PM and RDoc. She's super good to have around for any weirdness. Like I had a case. Has anyone heard of? See if I can remember the condition. It's rhabdomyolysis. They call it rhabdo. You've heard of it?
Yeah, I had it. My friend had it.
How bad was it?
It was. Oh my gosh, she was in the ICU for a while.
Yeah.
Because she overworked herself. She was like a power lifter.
Yes.
And it was horrible.
Yeah, it can kill you.
Yeah,
It can literally kill you.
She swelled up so much. It was
Yeah.
she was a completely different person.
Yeah.
And she didn't realize how it got into she passed out almost.
Yes. So basically, that's the exact kind of situation that caused it. It's an overuse condition, meaning too big a chunk of work at once, or too many days in a row, not enough recovery, or too steep a ramp-up angle into an activity, a physical activity. But basically, the body can't keep up, and the muscles start breaking down. Myo means muscle, lysis means cutting. So the muscles are digesting themselves and just kind of disintegrating. Now, it's not just muscles, though, because then they're dumping all of these toxins into your blood, and the kidneys start to fail. That's the thing that will usually kill you if you get. But I mean, it's horrible. So I had a patient, young guy, and he was 26, and he had 3 cases of rhabdo in 2 years. And the first time he got it, this is the most bizarre thing. First of all, three cases, and I heard each case. The first case was from eating a buffalo fish that was caught in a river in Louisiana, and it had toxins in it. And I was like, what? He said several other people in that town got cases of the same thing when I was there. I looked it up. Sure enough, buffalo fish are known to have toxins that can trigger rhabdo, basically trigger the muscles to start breaking themselves down, and then the whole process starts. He'd bought it in a fish market, and he was like, I'm going to eat clean and whatever, and he gets rhabdo. So that was the first case. And it presented mostly as thigh pain and swelling and weakness, like profound weakness, numbness in his extremities. And plus he was feverish, and he had no energy, and it takes you out. So that makes sense. Okay, so he had toxins. The second time, he had taken a gym class. He'd taken Class Pass, if y'all have heard of that. You can kind of tour different gyms. So he took one class, and he said, I did 2 minutes of sprints on a stationary bike. And then it triggered felt it coming on, he recognized the feeling, and he went home and rested and iced himself. Took 2 weeks to recover from that. And he even got the blood work done. It showed his chemistry showed, yep, this is rhabdo. That one didn't seem to make as much sense. We had a clear known trigger the first time. The second time, 2 minutes of sprinting, and he's a young, super fit, super healthy, super body aware, eats well, hydrates, sleeps well, doesn't drink, smoke, do drugs. I mean, he is the picture of health otherwise. And the third time, I can't remember what triggered that one. So I talked to Dr. Wasserberger, and she went down this list of things, and they were all valid causes or suspects, but we could cross them all off our list because they didn't match up with him. Then I thought, well, what if there's something, has anyone heard of a compartment syndrome before? So anyway, in a limb, you've got lots of different muscles. Muscles are just meat ropes, right? So you've got a whole bunch of them, and they're subdivided into little compartments of fascia. Just like if you eat chicken, you can kind of see that little filmy bit sometimes on chicken wings. That's fascia. It kind of subdivides the muscles and keeps them kind of roughly in the general vicinity. But fascia, it's like a really thin leather that kind of encases them. And it gives some integrity to the muscles so that they don't just disintegrate when you bump on them. So, but fascia, I theorized that when he had all that swelling and inflammation in his leg, he may have had some scarring in the fascia. So it no longer was stretchy. It was hard and encased. So anytime then, when you exercise, blood flows to the muscle swells, the pump, right? You feel pumped after a workout. So the fascia needs to be able to expand to allow that swelling of the muscle. If it doesn't, then the effect is constricting blood flow and neurology in there, and can trigger the same thing. So I said, let's go on this. I said, foam rolling. I gave him my foam rolling guidelines for his thighs. It was super painful, which is great news, because that's how you tell if you need it or not. I said, let's do 2 sessions of foam rolling in this week, and then I want to reintroduce exercise. That was all it took. And that was a year ago. He's been super active since, no more rhabdo. So that's the Dr. House kind of diagnostic detective thing. There was no good reason for him to have it 3 times in a row. As healthy as he was, and he was going pretty easy on exercise, But you get an idea, and you plug in the fix for that thing, and if he gets better, then that was it. So that was definitely a fun case. Y'all want to hear any more cases?
Yeah. Yes.
So tell me if I'm going over on time, by the way. So this other one is not quite as great a case, but there's some good parts to it. Young guy, 39 years old, came in to see me. He's a CrossFitter. He's active, he's fit, he's an executive, he does quite a bit of travel, plays golf a lot. And he said, "Doc, I have back pain, I have pain running down my leg." I said, "Has it happened before?" He said, "Yeah, 5 years ago." I said, "What did you do back then?" So, "Well, I went to an ortho, ordered an MRI, showed a disc bulge pressing a nerve that runs down my leg. He gave me an epidural steroid injection in my spine. Pain went away, it's been gone for 5 years." I was like, "Great." He said, "Then it came back." So I went back to the same pain management guy, got another steroid injection, didn't do anything. And so that's when he came to see me. So I checked him out and I found he had some pretty big mobility issues. Like, for example, a straight leg raise. If you're laying on your back, I should be able to raise one of your legs up to 90 degrees while the other one lays flat, and it feels easy to do. That's normal range of motion. 90 degrees feels easy. He had about 35. So I had really tight hamstrings, which is great news because, for one thing, tight hamstrings are the #1 cause for back pain. Super easy to fix. Tight hammies and glutes can also pinch the nerve that runs down your leg and give you the sciatica. So I said, let's work on this. I said, we're going to do a 2-session clinical trial. Meaning, if we see each other twice and you feel like, hey, I'm definitely starting to get better, great. We may need one more, and great. And if not, I'm going to order an MRI. I told him this on day 1. 2 days in, he's a little better. His pain levels are coming down. He's still got the pain. He's not dramatically better. Then he leaves town on a business trip, calls me, said, "Doc, it's way worse. I can barely walk. Nothing I do gives me any relief." So I ordered him an MRI in the town he was in, and the radiologist called me on my cell phone. So just so you know, that doesn't happen unless something bad is going on. So the way MRIs work, you order an MRI, about 2 days later you get a faxed report, if you're the ordering doctor. And then the report will lay out everything they see. If the radiologist calls you, it's because it's always the day they read it, and it's because something going on. He said, "Yes, Joe, it looks like he's got cancer, and it's in several areas." So as in his L5, L4, L3, one of his ribs, his pelvis. So that means metastases. Metastases just means cancer that has spread to not just the area where it started, it's gone to other organs, and that's the stage 4, that's the bad kind. In fact, his 3rd lumbar vertebrae, which is supposed to look like a nice little box, was completely hollowed out. There was no bone in it, and it had crunched down like a tin can. And he'd been walking around on this. So then, me, a chiropractor, has to call him and give him this news. Bless you. And that's not a call that chiropractors typically, expect to make, or a physical therapist even, But I gave him a call and I said, "Hey man,